Hello, my name is Randy Corfman. I'm a reproductive endocrinologist based out of the Twin Cities in Maple Grove. I've appreciated and enjoyed the leadership that Tara has had with the Everlasting Hope organization there in North Dakota. No, it's a big deal. It's an important thing for you folks to have access to a support group to support you, because you're not the Lone Ranger going through this journey. My background for coming out to see patients is based upon the fact I grew up on a farm outside of Wichita, Kansas, and I know how hard it is to get into town, to the big city, so to speak, to have things taken care of. And so when I finished my training at Yale, Mayo Clinic hired me to come set their test tube baby program up. So I left Yale to go to Mayo, which is great, except they wouldn't let me travel out to see patients in rural areas because their model is everybody comes into Rochester. So I left Mayo to set this clinic up, and I currently come out and see patients out in Great Falls, Montana, Minot, Bismarck, Fargo, Duluth, Minnesota, Wausau, Wisconsin. And if we can keep with the local team for their care, great. If we can, if they need to do in vitro fertilization, they stay there locally till they need their eggs harvested. They come here one day to get their eggs harvested and 5 days later to come back to get the embryos put back in. So we have a partnership with these physicians and these clinics across North Dakota and Montana and Minnesota and Wisconsin to provide care for them without them having to come to Maple Grove. One of the things that I think that has happened in our current medical systems is that in vitro fertilization is promoted as being the main technique that most people need to help them conceive, and I find that is not the case. I find that there are really about only 20% of people that I see as new patients really need in vitro. The rest of them, there's many other things we can do to help make the success rates good for them and have a reasonable chance of success. And so I'm going to outline that with you today and go through a protocol that we've had great luck with that I think that can be done with any of the clinics there in our area without needing to come to Maple Grove for the care. One of the things we're going to be doing in another later this week is a session that's aimed at your parents or your support network of friends and relatives who maybe help fund the infertility treatments or fund them in terms of emotional support. So they kind of have an idea about what you're going through and what kind of techniques and things will be applicable to you. And I know that we found that would have been a really nice thing for us when we're going through infertility, to have other people kind of share in understanding what we're going through. And that's what that session will be. So for those of you who have situations where you have loved ones who you would like them to know what's going on, that'll be a good session for them. So with that in mind, I'm going to kind of go through some basic review of the biology of reproduction in humans, so you have an idea about what we're doing. One of the things I want to tell you too about growing up on the farm in Kansas, which was great, I wouldn't trade it for anything in the world, but we didn't have kindergarten where I went to school. And so I never went to kindergarten. So my social skills and my drawing skills are bad, but that's my excuse for that. So with that in mind, we're going to head off on a basic review of how this works. Now, this is supposed to be a picture to show the female reproductive tract, again, drawn by somebody who has no artistic ability. Just above it, and this is a sheet that I use for filling out for patients before I see them. I go through the history before I see them, and for those of you who I've seen, you'll know that's how I do it. And there's 3 words here: proceed, adopt, or no children. And our patients find themselves here. And the idea is to make sure that when you have the consultation with whoever you go see, that you can come away from that with knowing what your options are. So here's how it goes. We have got to get the sperm and eggs to meet up here in the end of your fallopian tube. So to get out there, the sperm have got to travel from the vagina through the cervical mucus into the uterus, through the mucus here out to the end of the fallopian tube. And out here is where it will meet up with the egg. That happens if the egg has been released from the ovary. The tube picks it up, brings it in at the end of the tube. That's where the sperm will fertilize that egg. And that embryo is trapped inside of that shell. That shell is called the zona pellucida. And the embryo is trapped in that shell for 3 to 5 days, at which time these little cilia in the fallopian tube that first push the sperm out here reverse and go back in this direction, and the embryo hatches out of that shell after it bounces back and forth between the tube and the uterus. So the tube squeezes, pushes in the uterus squeezes, pushes it back in the tube. And implantation that will happen when the embryo burrows its way into the lining of the uterus, and sometimes it hatches and burrows its way into the fallopian tube, causing a tubal pregnancy. We want it to land in the uterus, and once it does, it establishes blood supply, and the placenta makes the hormone HCG, which is our first clue that a woman is pregnant. Now, here's the deal with the numbers. There are approximately 200 million sperm put in the vagina with intercourse. This cervical mucus is there to prevent any bacteria from getting through. So the normal bacteria in the vagina cannot get through, and the cervical mucus will open up and you will allow in 500,000 sperm. And then there's only 100,000 sperm allowed to make it out here. This is all under the control of the woman having a good ovulation event. So when you ovulate, you make a cyst on your ovary that's called a follicle, and in it is an egg, and the cells inside of that little cyst make estrogen initially, then later progesterone. And those two hormones work together to make the system work. So specifically, the lining of the uterus, let me get a different pen here, because this one is pooped out on me. So bear with me just a second. Okay. Got it. Okay, so the estrogen acts like a fertilizer, so to speak. Back to my agricultural background. And estrogen stimulates that cervical mucus to let the sperm into it. It makes the little cilia in the fallopian tube beat out in this direction, push the sperm out here. And it acts as a mitogen to make the lining of the uterus grow thick enough to hold on to the embryo. And it does some other things in addition to this, but those are the main three. When a woman's brain measures the estrogen level and know it's up to a certain level, her brain kicks out a signal. This signal does three things. It makes these cells change to make progesterone. It is a stabilizer. And what it does is to add stability to the lining of the uterus by causing blood vessels to grow into the lining to give a good place for the embryos to land. And it makes these cilia reverse to go back in that direction to help transport the embryo back in the uterus. So progesterone is really important. The second thing this hormone does is to make the eggs go from 2 sets of each chromosome down to 1 set of each chromosome, which is important because when the sperm comes in, if it's 1 set, you end up with a normal embryo. And last but not least is that this hormone LH causes the activation of enzymes in this fluid to chew the egg free. And so the egg can come squirting out and the tube can pick it up then to bring it in for the fertilization event. So ovulation controls everything, and we can't track the sperm and eggs, so we're stuck having to make some assumptions about couples who are trying to conceive. We want to assume, number one, that the sperm can fertilize the eggs, that the eggs can be fertilized by the sperm. And number two, we want to assume that fallopian tubes can work, that the uterus can work, and that woman as a host can carry the pregnancy and do so in a safe fashion. So that's important. And we can't track these things. We have to make these guesses. So we start out, number one, with the sperm count, so-called semen analysis. And the semen analysis is done 3 to 5 days after last intercourse. That's when the guy's count is going to be the best. And it turns out that everybody has a bad day once in a while. And so if it comes back abnormal, we just simply repeat it 1 to 2 weeks later. And if it comes back abnormal again, then we do some testing to see what's going on. See if we can identify the problem, if we can fix it. If it's fixable, great. If it's not fixable, then the three options that we have are using in vitro fertilization with a technique called ICSI, where we take one sperm and put it into the egg. So we don't need many sperm for that to work. Another option is doing intrauterine inseminations or artificial inseminations. The idea with that is you can slide a catheter through and squirt in several million sperm and bypass that drop from 200 million to 500,000 and put in at least 2 million moving sperm and have a reasonable chance of conceiving. The last option, this is nobody's first choice, is to use donor sperm. We'll talk about that in a minute. So that's how we evaluate the guy. From an egg standpoint, it's a whole different thing. And I want to show this sheet of paper to you. I'm going to zoom up here just a little bit. One of the things that is a difference between the man and the woman is the fact that a woman is born with all the eggs that she's going to have. So if you look at the number of eggs, it goes up and it comes down. So when she ovulates, she's using up some of those eggs. But when she was at 20 weeks of pregnancy in her mother's womb, she had 6 million eggs. And by the time she's born, she's down to 1 million. By the time she reaches puberty, she's down to 600,000, and she's going to run out of them when she's 50.7 years of age on the average. Now, there's some things that can make her run out of eggs early. For example, a woman's going to run out of eggs on the average 3.5 years early if she has a history of smoking. That's why cigarette smoking is something we really want to encourage women not to do, because it decreases the number of eggs they have, it decreases the effectiveness of those eggs working. So a woman is born with all the eggs she's going to have. So a 30-year-old, for example, has about 200,000 eggs remaining. There's about a fourth of them have major genetic abnormalities in them. And that's an underestimate because that's looking at 6 of the 23 chromosome pairs. So if we could look at all of them, for a woman who's 30 years of age, there's probably 40 to 50% of her eggs are genetically abnormal. Here she is going, using up her eggs at the rate of 20 to 50 a month. And her brain, when she went through puberty, became able to associate that eggs and estrogen go together. She makes follicle stimulating hormone from the pituitary gland, goes through the bloodstream into the ovaries, where these 20 to 50 eggs are scattered. And she's going to save the first one that can snag that hormone. And that follicle grows, and it grows at a specific rate. And we've learned some things from in vitro fertilization that we apply to non-in vitro, one of which is that we can measure the diameter of these follicles. And when they achieve a diameter of between 15 and 25 millimeters, we should have a mature egg, meaning that egg is down to 1 N. It can let the sperm in. And every cell in this follicle makes a little bit of estrogen. So she saves that one. The rest of them are destroyed by the ovary, never to be used again. Sometimes they hang around. And if they do, they form little tiny cysts around the periphery of the ovary. And that's a condition called Polycystic Ovarian Syndrome, PCOS. And Polycystic Ovarian Syndrome is something we see in a lot of young women, that these little cysts are full of testosterone, and testosterone tends to make the eggs not work normally. So anyway, that's how it works. And so as a woman gets to be older and the number of eggs she has goes down, the brain works harder and harder and harder to continue to squeeze an egg out of the ovary. And it's a random event if you save a good one or a bad one. So if you save a normal one, it's going to let the sperm in and go through the process. But if you save one that's really abnormal, it may not let the sperm in, or maybe normal to that, but not let it divide, or not let it hatch, or not let it implant. That's all under the radar screen. But if you have one that makes through all those hoops and it's still abnormal, nature's going to cause you to have a miscarriage. So let's go back to this 30-year-old. For those of you who are 30 years of age, you have a lot of eggs remaining. There's an 18% chance of conceiving each month. It's that low because there's such a high percentage of abnormal eggs. And nature is very good at shutting things down if there's something genetically wrong with the embryo. So you might look at it a different way. I know the way I first looked at it when I was younger was, wow, this isn't very good. The efficiency of reproduction is really quite bad. But in reality, if you look at it the other way, nature is really good at making sure that we don't have genetically abnormal kids. Now, sometimes some will get through the process and be abnormal and work, but on the average, not. Nature will shut it down someplace. Miscarriage rate is 15% for that woman at that age group. Fast forward, when she's 35 years of age, 100,000 eggs left, about half of them abnormal in one of those 6. If you look at all of them there, you probably have 70 to 80% of those eggs are genetically abnormal. Chance of getting pregnant each month, 16%. Miscarriage rate is 20%. You go on to age 40, fewer number of eggs, higher percentage of abnormal eggs, lower success rates, higher miscarriage rates, and so on and so forth. So that's kind of how it goes. Now, all of these numbers go according to a woman's date of birth. How many eggs she has remaining does not always go according to the date of birth. So sometimes there's a 35-year-old that will respond like a 30-year-old and vice versa. So we've learned over the years that we can do some tests to see, are you over here or are you over here? The tests that we do for looking at that are all based upon the understanding that we're looking at ovarian reserve. And it's important to note that ovarian reserve is measuring about how many eggs you have remaining. It doesn't tell us anything about the genetics of those eggs. The date of birth tells us about the genetics of the eggs or history of social things like smoking. So really what we're looking at here with this continuum is, it's like a bathtub. And the faucet putting eggs in was how many eggs you were born with, 6 million. And then as you get older, it goes down, and this drain size changes from month to month. Some months it's going to let more out, some months it's going to let fewer out. But as a woman ages, this level comes down. This drain then tends to have fewer and fewer eggs come out of it. And I think that's a good way, when I teach residents and medical students how this goes, kind of a good idea about how this goes. These tests, ovarian reserve, is testing where are you in this continuum. So one way is to look at the level of this hormone, FSH, on the 3rd day of your menstrual cycle. For this woman who has a lot of eggs remaining, this should be in the range of 4 to 6, 6 to 8, 8 to 10, equal to greater than 10. So for a day 3 FSH level, good news would be if it's under 10. Bad news would be if it's equal to greater than 12. Another way of looking at this is a hormone called anti-Müllerian hormone, AMH, anti-Müllerian hormone. The higher that number, the more eggs that she's releasing that month. So it's an indication of ovarian reserve. Again, it has nothing to do with the quality of the eggs, but rather how many eggs she has remaining. So an AMH level, if it's equal to greater than 1.5, we think that she has a reasonable number of eggs remaining. If it's less than 1.0, we're thinking there's not many eggs remaining. It's important to note that this test is done really mainly for women who are going through in vitro fertilization to determine how many eggs are they going to make if they do in vitro fertilization. But for most of you, we don't need in vitro fertilization, and rather we would do some things to make ovulations more healthy. Now, I'd say about half of the women that we see, their problem basically is they're just not making enough of this follicle stimulating hormone to save a follicle. All we have to do is to make this go up a little bit. And as women mature, we'd like it to go up maybe not just that far, but maybe go up that high to increase the likelihood that one of the eggs that you save is going to be genetically normal. That's the rationale. That's the mode of action of most of the oral fertility medications. Now, estrogen dictates how much of this hormone the pituitary gland is making. So if we can make the estrogen level go down, we can make her ovaries respond by making more follicles. We can increase the level of follicle stimulating hormone, and it works really quite well. Now, the way we've done this in the past, up until about 7 or 8 years ago, was to use a drug called Clomid. Clomid is an anti-estrogen. And anti-estrogens work by binding on any cell in the body that has an estrogen receptor and make that cell think that the estrogen levels are low. It works well here because if we can make the brain think that the estrogen levels are low, she will make more follicle stimulating hormone and it will rise and she'll save a follicle. And so this drug Clomid, or clomiphene citrate, has been widely used for 50 years. And one of the problems that it has is that it has a number of side effects. Specifically, it's an anti-fertilizer. And it tends to work in a negative way wherever estrogen works in a positive way. So it tends to make the cervical mucus less likely for the sperm to penetrate it. And we really don't have a test to see if that's happening. We used to have a test called the postcoital test that can be done to evaluate the cervical mucus to see if the sperm are getting through. And it's been shown to be such a bad test that nobody uses it any longer, haven't for several years. So we're kind of stuck not knowing about that one. We know that Clomid can have a negative impact upon the cilia and the fallopian tube. In fact, there's a paper published 40 years ago showing that there might be an increase in the risk of ectopic tubal pregnancies in women who take Clomid, and the thought was the anti-estrogenic side effect can have a negative impact upon the cilia. So that was a problem. Last but not least, and maybe the most important, is it tends to make the lining of uterus not develop appropriately. Now, it's easiest to say it makes it not get thick enough to hold on to the embryo, but that's not really accurate. It does something to change the characteristics of the endometrium to make it less likely for embryos to implant. But we're stuck that that was the only oral fertility drug we had until several years ago when a group out of Canada published a series of papers showing that they could use a medication to inhibit an enzyme system in the ovary called the cytochrome P450 system that takes testosterone and turns it into estrogen. So this drug called letrozole, also known as Femara, works by blocking this enzyme system so it can't convert this to this, which makes this go down. The brain then responds by putting out more follicle stimulating hormone. And it might make this much, it might make this much, it might make this much or this much. It's not really predictable. We don't want her to save more than 3 eggs because the risk of multiples becomes too high. Now, in our practice, starting about 8 years ago, we quit using Clomid and we used letrozole. And we found that rather than having at least 3 major side effects that Clomid has, letrozole has 1 side effect. And that side effect is that for 70% of women, it lowers the estrogen level so low that there's not enough estrogen to make the lining of uterus grow thick enough to hold on to the embryo. When we discovered this, we were able to circumvent it by simply adding on some estrogen pills. Estrase. Estrase is 17-beta estradiol, the same estrogen the ovary makes, and we can add it on and circumvent and bypass that problem that some women have to letrozole. And when we made that discovery, letrozole work extremely well. to the point that we quit using Clomid except in rare cases, and we had much better success rates. In fact, we helped a lot of couples conceive with that, making it so they do not need to go through in vitro fertilization. And it had a marked decrease in the number of people in our practice that needed to go to in vitro fertilization. So I think it's important for you to know that if your physicians have been having you treated with Clomid, you might want to talk to them and see if they would be considering changing to letrozole and to use a protocol that can circumvent the side effect that letrozole has. Now, I want to show you a problem that both Clomid and letrozole have, and that is that this follicle stimulating hormone stimulates that follicle to grow, and it grows, and we can measure the diameter of this with ultrasounds. The brain is sensing when this estrogen level is up to a certain level, and when it gets to that point, the brain kicks out LH, luteinizing hormone. Same part of the brain that makes FSH makes LH, the ovulation signal. And LH does at least three things. I'm going to zoom in here a little bit. It goes up and comes down. That's why they call it a surge. When it gets up to here, the cells in the ovary, the granulosa cells, stop making estrogen or decrease the estrogen production, start making progesterone. When it gets up to this level, your eggs go from 2 sets of each chromosome down to 1 set of each chromosome. When it gets up to this level, the enzymes are activated in that fluid to chew that connection free. So the egg is floating around inside. And if we wait a little bit longer, the same enzymes chew a hole through the wall of the follicle and the egg comes squirting out and the woman ovulates. We've learned a number of years ago that nature knows that it is not a good thing for a woman to have multiple pregnancies. Where other animals might get away with having litters, humans don't, and nature prevents that by making these cells that are making estrogen and progesterone also make a protein called inhibin. Inhibin's function is to make it that the LH surge does not go up high enough to ovulate. It might go up this high, or this high, or this high, but not hit all the thresholds that are necessary. Now, some of you may be using ovulation predictor kits to figure out when the LH surges happened. And they do a really good job about telling you when your brain kicked out that signal, but it does not tell us the amplitude or how high the LH surge went. So if it goes up this high, you don't ovulate. This high, not. It's only if hit all those thresholds. Well, we've learned some things again from in vitro fertilization, and that is that we can have the woman take an injection of a hormone that does the same thing as LH, and that hormone is HCG, the pregnancy hormone. Biochemically, there are the same decapeptide, 10 amino acids. This one has a bunch of sugar stuck on the outside of it to make it so the half-life is longer. So we can give a shot of this HCG that we call the trigger. So some of you may have heard about our patients getting the trigger injection. When the trigger is given, if I look at the percentage of eggs that are ovulated, we know from our experience with in vitro fertilization that 50% of those eggs are gone 40 hours after that shot's given. None of them are released at 36 hours. All of them are released at 44 hours. So when we have the trigger shot given, this is the time that we want to have sperm around. We can use that very precisely to know when intercourse needs to happen or when we do intrauterine artificial inseminations. So I wanted to point this out to you because when I see couples that have gone through Clomid or letrozole treatments, it's important that the trigger shot be administered. And it's important that the the romance or the inseminations need to be performed in this time period. I've seen some couples have the inseminations performed 24 hours after that trigger shot's given. It's just too early. We need to wait till 36 to 40 hours later. So we ask them to have the insemination or romance to happen in that time period. Whether it's inseminations or whether it's romance depends upon the sperm counts, and it depends upon what medications the woman is upon. So for example, if this woman is using Clomid, we know it can disrupt cervical mucus, so we would do the artificial inseminations if she's on Clomid. If his sperm counts are low, we can do intrauterine inseminations and bypass that drop from 200 million to 500,000 by just sliding a catheter in and putting in several million sperm. In fact, we know that we need equal to or greater than 2 million moving sperm. There's some suggestion in the literature that we may need to increase this number to 5 million moving sperm. But I think I have personally a bit of a problem with that, in that I think that programs are pushing people toward in vitro fertilization when they may not need to use it. We've seen pregnancies happen with less than 2 million moving sperm. We've seen them happen with less than 1 million moving sperm. All we've got to do is get one sperm to get into her egg out here. So that's the story. That's how we use fertility medications and how we use ovarian testing to see what's going on from an ovulation standpoint. So no matter how young you may look or feel, when you're 40 years of age, there's a high percentage of those eggs are genetically abnormal. And what we're doing for most couples that we're seeing, we're either helping them have a healthy ovulation event, or we're helping them save more than one egg to increase the likelihood that one of them is going to be genetically normal. We're counting on this system, getting rid of genetically abnormal embryos. So that's the story there. Now, I'm going to change gears now. We've talked about eggs. We've talked about sperm. I want to show you a little bit about sperm. Please forgive my bad artistic ability here again. We've got the testicle. We have the epididymis. We have the vas deferens. Comes out through the prostate, which is at the base of the bladder. The sperm in the testicle are round. As they develop, they come into the center of the testicle and they enter into the epididymis and they develop a tail. Then they swim out through these channels, and once they emerge at the other end of the epididymis, the tail is wiggling. That's supposed to be a wiggling sperm. And comes out the vas deferens and out through the prostate. Now it turns out these glands secrete a substance that strips the cap of the head of the sperm off, and that activates that sperm to have enzymes exposed that are there to chew their way through the eggshell, and out the sperm comes. Now, there's a barrier between our testicle and the bloodstream such that guys do not let any sperm get into our bloodstream. But sometimes that goes awry. So for example, you might get hit in the groin with a hockey puck, or the bicycle handlebars, or a baseball takes a bad hop and hits you in the testicles, and it hurts, but it also can do some damage and break that barrier so some sperm can get put into the bloodstream. If we do that, we can become immunized against the sperm, and we make antibody molecules that can be concentrated in these glands. Now that can become a problem because when the sperm comes out, the antibody molecules have at least 2 binding sites, and it can cross-link the sperm, and that can make their motility go down and cause problems for the sperm getting where they need to be. There's some things we can do to wash those antibodies off, and that is a technique that we sometimes use with intrauterine inseminations to improve the motility of the sperm. But for guys who've had vasectomies performed, the vasectomy has simply an interruption of the vas deferens, And one option they have is to reverse this surgically, have a urologist who's specially trained with microsurgery to go in to hook these two tubes back together. And it works pretty well. As long as that vasectomy has been performed no later than 7 years prior to the time we see them. If it's been more than that, the chances of getting sperm retrieved go significantly down. Sometimes there's just an absence of part of the vas deferens, and we can go in with a little sample and take a small sample of the testicular tissue out, send it off to the lab. They evaluate it and freeze the sample. So then we can use that frozen sample for doing in vitro fertilization. So that's an alternative. But for most couples, they don't need that. This is a system that we're dealing with. So we've already talked about how we can deal with sperm by doing artificial inseminations or doing in vitro, or to change the model and use donor sperm. From an egg standpoint, we can use fertility medications, letrozole preferably, to make her have a better ovulation event, or to make an extra egg or two if she's getting into 35 years age group or older, to increase the likelihood of her saving a normal egg. Because I'm pretty sure there's normal eggs in a 40-year-old or even in a 42-year-old. The problem is we don't have a way of teasing the good ones out and leave the bad ones behind. Okay, so that's how we use testing. We use sperm counts. We do these tests to see how the ovaries are working, see if we can do things to make them work better. There's a condition called Polycystic Ovarian Syndrome that I want to tell you about a little bit because we see a lot of couples that this is an issue. And I want to draw this out for you how this goes. Now, it turns out the pituitary gland makes follicle stimulating hormone, as we've seen, and it goes into the bloodstream and it makes her save a follicle. So here you are using up your eggs at the rate of 20 to 50 a month. Follicle stimulating hormone has to rise to save one. Sometimes it only goes up this high, and we like to know why. Follicle stimulating hormone goes through the bloodstream into the ovary to stimulate that follicle to grow. And again, there's an egg inside of it that's stuck on the follicle wall. And when she kicks out the LH surge, it chews the egg free, and eventually the egg comes squirting out of the ovary and she ovulates. And it turns out that if I do a magnification of this part of the ovary, like this, these cells are called theca cells. These cells are called granulosa cells. And it turns out that the theca cells make testosterone and another male-like hormone, androstenedione. And these hormones diffuse into the granulosa cells and are converted into estrogen. So again, you have to have androgens or testosterone around to make estrogen. But if you have excessive amounts of androstenedione and testosterone around, it goes back to the brain to inhibit the release of FSH. And that makes us not go up high enough to ovulate to save one. So you're still using your eggs up all the time. You're just not saving any of them. Well, we've learned some things about what causes excessive amounts of testosterone and androgens to be made. There's two places that can make that become a problem. One of them is that stress hormones made by your adrenal glands can be converted into androstenedione, testosterone, and estrone, a weak estrogen, that is mediated by fat cells, which we all have. Some of us have more than others, but we've learned that if the body mass index is equal to greater than 30, that alone can make enough testosterone to make the system not work right. Not only does the overproduction of testosterone make this not work right, it also acts as a toxin to make the eggs not work right from a chromosomal standpoint when these eggs are being stimulated. Makes the miscarriage rate higher. But not all women who have this syndrome are overweight. Others who have this syndrome develop it because they've inherited a genetic variation such that when they eat a meal and their blood sugars goes up like everybody else's, the pancreas responds by making a slight increase in the amount of insulin. And insulin goes right into the ovary to make it overproduce testosterone. Now here's how this works. There are receptor proteins on the surface of these cells that are specific for a small protein called insulin-like growth factor number 1, IGF-1. And I'm going to draw it looking like this. IGF-1 is made by these cells that comes back and plugs like a key into a lock. And when that key plugs into that lock, it turns this on to make more of this, which makes more of this, which makes more of this, which makes more of this, to get this vicious cycle going. And that's what enables that one follicle to grow and the other one's not to grow. Insulin, like growth factor number 1, is named that because it is very similar to insulin. But if a woman is making too much insulin, more than she normally should, these receptors are bound onto that insulin, and that can make the overproduction of testosterone happen. That's the mechanism of action of how polycystic ovarian syndrome tends to screw things up. So a common characteristic of these individuals is that they have a family history of type 2 diabetes, because what happens long term is these people develop adult onset diabetes. Type 2 diabetes. They tend to have symptoms of hypoglycemia. They eat a meal, their blood sugars drops lower than most people's do. They get more tired and sleepy after they eat a meal. They tend to get grumpy and they get the so-called hangries, and that tends to make them not feel right. And so that could be a tip-off of what's going on with this. Another tip-off for this condition is that they might have acne or abnormal hair growth called hirsutism. Those are all clues that this woman might have polycystic ovarian syndrome, family history of type 2 diabetes, evidence of too much testosterone, irregular cycles because she's not making enough FSH. These little follicles that don't make it, they tend to form these little tiny cysts around the periphery of the ovary that are full of AMH and testosterone, and that tends to make the system not work right. So my point with telling you all that is, one of the second things that I see a lot of people that have had previous infertility treatments that in my opinion have been suboptimal is that if you don't do something to lower testosterone levels before you make them have better ovulation events, all you're doing is helping make them make bad eggs, which doesn't do any good. So it's important to treat the polycystic ovarian syndrome before you get started with fertility medications. And there's some easy ways to do that. Talk to your healthcare professional about that, and they can help guide you through that process. Okay, so we've talked about sperm, we've talked about eggs, we've talked about ovulation. Let's talk for a minute about tubes and uterus. Now, there's two ways to look at fallopian tubes. One way is to look at the inside of them with a test called an HSG. Hystero is Latin for uterus, salpingo is fallopian tube, gram, photograph. HSG, that's done between days 5 and 12 of your cycle. It's to put X-ray dye inside the uterus. So we put a speculum in the vagina, clean off the cervix, put a catheter in, put fluid in that shows up on the X-ray machine, and you watch it come out through the tubes. It's diagnostic to show your tubes are open. It's also therapeutic. When that dye goes through the tubes, we feel it gives them 9 to 12 months of optimal times of conceiving. It's very effective with diagnosing the tubes and to see if they're open, and it flushes them out at the same time. So it's like killing two birds with one stone. Another way of doing it, to look at the outside of the tubes, is to do a so-called laparoscopy. where a surgery is performed, where you go to sleep, a general anesthetic is given, a telescope is put down through the belly button. We make a couple of incisions, we look inside and we can see this view. And we can see, is there something that's making the tubes not pick up the egg? If there's something that's making through the egg can't get picked up by the tube, most commonly that's pelvic adhesions, that somehow some bacteria have gotten through this barriers. And once it gets to where it's not supposed to go, nature lays down scar tissue to sequester it. And that can disrupt the ability for the tube to pick up the egg. But it's a pretty invasive procedure. It's a general anesthetic and there's risks and complications can happen with it. So we generally use a hysterosalpingogram to evaluate the fallopian tubes. Because it flushes out the tubes, it can be done in an outpatient setting. Now, if I think of it, I'll try to give you some tips on how to make this be a pain-free procedure. We'll discuss that a little bit later. So those are two ways to tell about the tubes. Ultrasound tells us a lot about the uterus and the muscle of the uterus. Hysterosalpingograms just tell us about the inside. It doesn't really tell us about the muscle of the uterus. Ultrasound can do it. We bounce sound waves off the tissues and we can see, is there something there that's going to inhibit the ability for the uterus to function normally. We can pick up some tumors called fibroids occasionally with that. They can be surgically removed or left in place depending upon where they're located. And so we can tell about that. Okay, so I wanted to tell you folks that and to then lead you through the average pathway that we find for most couples that we're dealing with when we see them as patients. We do a semen analysis. We do some testing to see how the ovaries are working. Then we use this letrozole protocol, and here's how we do it. You call us when your period comes, and you get an ultrasound on day 1, 2, or 3. You take the letrozole, 5 milligrams, 2 tablets. There's several different doses have been examined. We feel that the literature supports using 5 milligrams as a starting out point. We give those days 3 through 12. We plan on 10 days of it. Sometimes we use 5. Sometimes we do go out to 18 or 19. We figure out how many days to give it by doing an ultrasound on day 10, 11, or 12. When we see that we have a nice follicle with a diameter between 15 and 25 millimeters, we have them take the trigger shot. Trigger shot is given. We want them to have romance the night of the injection. If the sperm counts are normal, if they're not, we don't do that one. And then either they have romance or an intrauterine insemination at between 36 and 40 hours later. That timing is critical, as when the eggs are going to be in the tubes. So we just tell the gal, look, when the follicle's the right size, you need to take the trigger shot tonight. Call your husband. He needs to bring some chocolate and roses home. We're having romance tonight. And again, on this one, this is the most important one, because remember, we talked earlier about the fact that when that trigger shot is given, that 36 to 40 hours later is when the 36 to 40 hours later is when the eggs are going to be in the fallopian tubes. We add on estrogen, estrase, if the estrogen level is low, less than 150. So when we have a nice follicle, the first cycle of it, we check an estrogen level. If that's equal to greater than 150, we think that side effect is not a problem for you. If it's less than 150, we just simply add on estrase, estrogen pills, that goes all the way through the first trimester of pregnancy. So folks, when we discovered this, it made our success rates go up remarkably with letrozole, to the point, instead of realizing an 18% chance of getting pregnant on your own, it goes up to 22%. It works much better. We always add on, in our practice, progesterone in the second half of the cycle, because we think you can't get too much. This process, after a hysterosalpingogram has been performed before you start it, after a semen analysis has been performed to make sure that we got enough sperm to work with, And we've done endocrine testing to see how well your ovaries are going to work. We do this for no more than 6 cycles for women under 35. It goes like this. For women that are less than 35, we do it no more than 4 cycles for women that are equal to or greater than 35. After 6 months of doing this, for this woman, there's 60% of them pregnant. There's 40% pregnant after 4 cycles for this group. The success rates per month goes as follows for the under 35-year group. 22% the first month, the second month, the third month, 18%, 12%, 6% becomes less than 1% per month. That's what we do to try to optimize the chances of voting and to put a limit on how many cycles of it you do before you move on to something else. Because once you're out here to less than 1% per month, it's a problem. Now, why is it dropping off? The most common reason is the assumptions that we're making may not be valid. It may not be true that the sperm can fertilize her eggs. It may be her tubes really are not picking up the eggs and her uterus isn't holding on to them. And it's at that point we stop and we question the assumptions. And that's when we do in vitro fertilization. With in vitro fertilization, we have the woman take injections of this follicle stimulating hormone. So instead of just saving 1, 2, or 3, we save all of them that we can get, good ones and bad ones. And then we make use of that by putting these sperm directly into the eggs with that ICSI procedure, most commonly to make sure they fertilize. So that's kind of the flow chart. And I would say that most couples that we see will not need in vitro fertilization. We can figure things out less invasively than with in vitro fertilization. Remember earlier I told you that about 80% of people we see don't need in vitro fertilization. They either don't need it or they change gears and they do something different. They may change their direction by, instead of doing in vitro fertilization or oral fertility medications, they may choose to go to donor eggs or to donor sperm. So there's some other alternatives that are important. So I want to kind of go through that with you about how in vitro works for those of you who need it. Basically, there's some preparation that's done first. Preparation involves doing a sonohystogram to make sure the inside of the uterus is normal. We like to freeze sperm. So we have that on hold for the day of the egg retrieval. So if they're sick or can't give us a sample, we have that in the bank. We do some infectious disease screening the FDA mandates. We do testing on her ovaries to see how her AMH levels are looking and how her day 3 FSH levels are working. Because it will give us an idea about whether or not this is something that they should be pursuing or not. Because we want to make sure that when she goes in to have her eggs harvested, that everything is looking perfect. Then we do the stimulation. Now, every IVF clinic stimulates a little bit differently. We all think we're doing things the right way, but basically it involves taking injections of follicle stimulating hormone 2 times per day, times 10 to 12 days. We're watching the follicles grow. We know that when they achieve a diameter of between 15 and 25 millimeters, we should have a mature egg. She takes a trigger shot. The eggs start floating around inside as they become chewed free from the follicle wall. And if we wait a little bit too long, she will ovulate those eggs and we missed them. We've learned that we can put a needle into the follicle and suck out that fluid at 36 hours and we get the eggs. We get eggs out of 80% of those follicles. Ultrasounds and blood tests are performed at the satellite clinics in Great Falls or Minot or Bismarck or Fargo or Grand Forks or Duluth or Wausau or Anchorage, Alaska. And when they're the right size, the trigger is given. Trigger shot is given, and then we get the eggs. We take the eggs by harvesting them. It turns out that the good Lord put the ovaries about 1 centimeter from the top of the vagina. So we don't have to do surgery. We just put an ultrasound probe in. I put a little tiny needle in the follicle to aspirate the fluid. We get the eggs. We put them together with the sperm to give you embryos, and we grow them a number of days. And we grow them to the point that we put in 1 embryo on the 5th day or 2 embryos on the 5th day. And any left over, we freeze. And the success rates are going to vary depending upon the age of the woman and the age of the guy. One of the things that I wanted to show you that I didn't hear earlier was that we know the woman is born with all the eggs she's going to have, but it is true that a guy's sperm lasts really only 72 days. That's why it's gotten guys off the hook traditionally, because we're thinking the guy's age made no difference. But in fact, we feel that when a guy's over 42, the risk for miscarriage, autism, and some mental illnesses start to go up in our offspring. So if a gentleman is over 42 years of age, we just advise them that there's some significant risks that go along with that in terms of reproduction. It's important for them to know that. So I won't go into the details about what days we put these embryos in, but we just generally tell people, don't put back in more than you're willing to take home. So we put in 1 or 2. We freeze the remainder. Some couples do not want to have responsibility for a lot of embryos, and they will consider letting us use some of the eggs for in vitro fertilization and to freeze the remainder, because then you can thaw those out and use those without going through this whole expensive thing again. And it can save them the angst of what to do down the road. So for example, what if they put in 2 embryos, they have twins, they don't want any more children. They got them frozen, they got to use them, or they could donate them to other couples, or they could discard them. And if they don't want to do any of these 3, then they should limit how many eggs they let us work with. In our clinic, I don't like to work with less than 6 eggs, because I think success rates are markedly lower when that's the case. So, but it's important to never let yourself get into a position to make some decisions that you regret later on. I think that's kind of what gets it back for me to go back to the beginning, which is this. If you proceed with trying to conceive, these are the things that we're dealing with. These are the assumptions we're wanting to make. Those are the tests that we're doing to make those assumptions. But it might be that you say, you know, we're not okay with these alternatives, and then to adopt, or to say we're not going to have kids. We're going to have child-free options in our lives. It's just important to have that all in mind. So that's an overview. And again, I think that there's advances in what we know about these oral fertility drugs to make it so we don't use Clomid really at all in our practices anymore, and use letrozole, and it's been extremely helpful. It is just important to note that every drug that we use has side effects. And the question is whether or not we can detect what those side effects are, and can we get around the side effects. And I think that letrozole has really been an amazingly great medication for a lot of couples, some of which have gone through multiple cycles of Clomid already, and nothing has worked. They come to see us because they think in vitro is their next step. But if you can use letrozole and circumvent those side effects, we don't think there's any real reason to go right to in vitro fertilization. Now, one of the things we keep in mind is this impact of age on reproduction. You know, percentage of abnormal eggs goes up with time, and in our textbooks, we define infertility as after a couple have had 12 months of unprotected intercourse. If it hasn't worked, that's an infertility issue. Well, I think when you look at the information and you think about the percentages of abnormal eggs going up exponentially at age 35, that we don't wait for a year for them to try. We do some testing to see early on if we can identify what the problem is and try to get around the problem. Now, a couple of things just to tell you some old wives' tales. It used to be thought that that the woman's position after you have intercourse is going to be important on letting the sperm get the right place. That's been shown really not to be the case. It doesn't make any difference position. One of the things we've seen couples use use lubricants for having intercourse. And the problem with lubricants is almost all of them are really bad on sperm. We had a couple from the Dakotas actually that she sold a line of products called Pure Romance. And so they came to see us and she said, hey, you told us that these lubricants might be a problem for sperm. Can you test them? So we test 3 of their main products and they all were bad on sperm. So you got to be really careful with what you use. KY jelly is bad on sperm. Saliva is bad on sperm. Baby oil is bad on sperm. Canola oil, just plain old canola oil, works pretty well as a lubricant. So we suggest if you need to use a lubricant, don't use much of it. And if you're going to use it, use mineral oil or canola oil. Works quite well. One of the things that we know is that the act of that egg coming out of the ovary depends upon the enzymes activated to chew it free, so it's floating around. Aspirin can inhibit the ability for the egg to be chewed free because those enzymes are blocked by aspirin and aspirin derivatives. So ibuprofen, aspirin can be really a tough thing. If you have a headache before ovulation, our advice is take Tylenol and not an aspirin derivative because it can inhibit, in theory, the ability for the egg to come out of the ovary. I think that it's important to understand that there are some things that can be done and to never let us push you by where your limits are. Don't go, if you're getting to a point down this proceed route, but there's some alternatives that you just don't feel comfortable with. Just don't do anything that you regret down the road. And stop and ask for help. You are blessed with some really good healthcare providers in the state of North Dakota, Montana, Minnesota, Wisconsin. And fortunately, these ultrasounds can be performed at virtually any of those cities I mentioned. And it doesn't mean that you have to come to the big city to have this technology to make use of it. So I think you really nowadays have some really good options. I have not talked about in vitro fertilization and the using pre-implantation genetic testing. I will just mention that when you start adding that on, you're adding on significantly to the cost. And for most of you, you don't need genetic testing of your embryos. In my opinion, it raises the cost not quite double, but almost to go through that technology. And then you're in the area of doing testing that may not even be necessary. It's been shown that these biopsied embryos can sometimes self-heal. And what might have looked to be like a genetically abnormal embryo might have turned into a normal baby. And so I think that we have chosen to limit offering that just to people that need it. Like, for example, if both of you are carriers for cystic fibrosis, that would be a reasonable thing to do. Make sure your child does not have cystic fibrosis or hemophilia. There's a number of other genetic abnormalities that we do offer the testing for. But just to do it across the board, I think it's just not really a reasonable thing to do. And I think it's an overuse of the technology. We also elect not to freeze all the embryos in our program. And the main reason for that is that there's somewhere between 5 and 10% of couples have no embryos make it through the freezing and thawing. They went through the whole thing for nothing. So we tend to put in just 1, maybe 2 embryos with a fresh cycle, have some embryos to freeze. With that, I think I'm going to close and let you know that you're not the Lone Rangers again going through this process. A lot of people are having trouble conceiving. We see a lot of people that are struggling with infertility, but fortunately with the technology that we have and the understanding of different medicines, we can really help many of you have children. And to make sure though that you know what you're getting into. and what these percentages are showing. And with that, I'll just leave it that if you have any questions for us, you can call us at 763-494-7700. That's 763-494-7700. Or go to our website at www.mcrh.com, Midwest Center, reproductivehealth.com. Our gals can help tell you about when I'm going to be in different places and different times of the month. And also to know that now with the one of the few positive things that come out of the COVID infections is that telemedicine is getting covered by many insurance companies. Before COVID, they weren't covering it. You know, they would not cover you to have an in-person, a phone visit with me. But now with telemedicine, they are covering it. So it really opens up a lot of possibilities for you without having to travel even to those towns I'm just talking about, not have to wait for the month for me to come out to the next time to see patients there. So that's the story, you guys. I'm sticking with it. And I wish you the very best of luck as you're going through a very difficult time. If you have loved ones that you'd like them to know what you're going through with infertility, the session I'm going to do that I think Tara's going to put on Thursday night is going to be meant for them. I think these will be videos that will be accessible for them for other times as well. But with that, I'm going to say goodbye and wish you a good night. And thank you for letting me have a chance to spend an hour with you. Best of luck to you. Okay, bye.